So after the talks on the principles of vitrectomy and the nucleus removal, I'm very grateful to Haripriya Madam for this opportunity to talk about cortex wash in the presence of PCR. I'm very grateful to Haripriya Madam and Dr. Chandrashekharan and Dr. Vivekanandan for sharing their videos. So we know that capsular complications preempt the placement of IOL in the bag, which is the ideal position. And among the capsular complications, posterior capsular rupture is the most common. And early recognition and minimizing damage gives better outcomes, as we see. But at whatever stage the PCR occurs, the remaining steps have to be carried out. So whether it is during nucleus management or cortex wash or later, this has to be carried out interspersed with vitrectomy whenever vitreous intervenes. And simultaneously, we need to take care that lens matter does not luxate into the vitreous when we are doing these steps. So a challenging situation arises when a PCR is detected with all or some significant cortex remaining, and the surgeon usually is a little deterred by this condition. But on the flip side, we have to remember that wherever there is cortex, there is a PC, and the surgeon should take heart that he still has some support to place the IOL. So what would be the problems of cortex in the presence of a PCR? Ideally, it needs a thorough cortical removal. So we should be removing out 100% cortex. There can be an enlargement of the PCR on repeated attempts or repeated collapse of the chamber during the process, or it could be because of some wrong techniques like pulling on the PC. Cortex removal may become more difficult when vitreous presents, and instead vitreous may be aspirated. And in turn, this leads to causing traction on the retina, which can lead to immediate to even late post-operative complications. And during this process, the cortex may drop into the vitreous. So we look at some of the videos where we'll see some of the principles of cortical wash. So here I am not still sure, it's an opening which I see, it's a PPC. So what I am doing is I am stripping off the cortex. I am still using the coaxial IA, and while I am doing this, I notice that there is a line which I see here to my right, and once I decide that there is a PCR in this case, I am not stripping it past the center, but now I see the line, and once I see here you can see the line, so I fill the chamber with viscoelastics, and I am more comfortable with making a new side port and using a dry Simcoe cortical aspiration in order to take the rest of it. Now this sort of ensures that I remove the cortex without breaking the anterior vitreous face. Coming to the dry cortex wash with Simcoe, when vitreous is already presented, we go ahead with the vitrectomy with the chamber filled with viscoelastic in this case. And then you have the entire cortex remaining, and with the Simcoe, we carefully hold the cortex and peel it off the PC. So what we have to take care is that the Simcoe aspiration port is completely plugged with cortex, especially when passing through the area of the PCR, so that it does not catch vitreous on the way. So you can see that this is being carefully done. Better would always be to go for a retroillumination, which gives you a very good view. And the other principle that you should remember is that you take the cortex away from the area of the PCR, as you see here, and any decompression of the globe can lead to a sudden prolapse of the vitreous in between. So you can see here that after this piece, there's a bulge in the PC you can see. I confirm it with the movement of the PC with the help of a spatula. So now it means that I need to do some vitrectomy. It isn't there, it is here. So I do a vitrectomy again and then proceed with removing the rest from the two corners of the PCR. So after ensuring that there is no more vitreous, I just go ahead and carefully peel it off, and so you can see the other end of the PCR. Now a little bit of the cortex in the periphery may or may not be problematic, but it's good if you can really get an access. Now the other principle is that you should always strip this towards the away from the towards the PCR, not away from it. So you can see that this last piece remaining, I can actually have I could have actually gone from the PC tear to the periphery, but I take pains to strip this final bit off and towards the PCR. So this explains majorly the principles that we need to follow. Whenever there is a large PCR with vitreous loss, you may not be able to see the cortex, but that doesn't mean it is not there. So we have to judge if any cortex is present after doing a vitrectomy. So once you do a vitrectomy, the cortex wash becomes easier, and then you will see that the PC also actually unfurls towards the center, and it's actually much smaller than what you initially saw. And if you can't have see the vitreous and the pupil is small, it will always be worthwhile to go with using the iris hooks to dilate the pupil, and then go ahead and remove the cortex from around the bag. Whenever cortex intervenes, you know it, you are not able to get a hold on the cortex, and you see that it's immaturely the vitreous is getting pulled. So at that stage, doing a vitrectomy will help in getting the cortex out better. So we saw cortex wash with the Simcoe and with the IA probe, and in which conditions we can do it. Here we will see it with the vitrectomy probe itself in the IA mode. Now this can be done whenever we are expecting that vitreous loss may happen or vitreous may present during the process of cortex wash. So here you can see that this surgeon used a 2500 cut in the cut IA mode. The vitrectomy has been done, and now the surgeon goes with the vitrectomy probe in the IA mode. Look, the cuts have been converted to 0. The surgeon is using it only in the aspiration position, and it's been carefully teased out, taking care that none of it gets dispersed into the central opening or into the vitreous. So this is being carefully done, and as I said, the advantage of this is you will now notice is when this is being done, in case vitreous presents itself, you can always stay inside, convert to cut IA mode, and then cut the vitreous and proceed with the rest. So here when you see this is being teased out, there is presentation of vitreous. The surgeon immediately reaches the area of the PCR, converts to the cut IA mode, and you can see it goes at 2500 cuts per minute. And after this vitrectomy, the remaining cortex will be removed. So what are the problems of residual cortex? One is that it can cause low grade to significant iritis, and the iritis may stay for a very prolonged time. If we leave behind some of the cortex, like the cortex that I showed in that second case, then that can opacify on the PC, and if it is in the pupillary area, it can obscure vision. So it may look as a transparent sheet when we are leaving it, but later opacification can cause problems. If there is a significant chunk of cortex in the periphery or on the PC, we need to undertake a resurgery for the cortex removal. And now this is more fraught with risks, because it increases the risks of endophthalmitis, and instability of the IOL is also possible, and you may need to use some other techniques like fixating it to the iris, which we will see later. And a residual cortex adjacent to the PCR can actually become more fluffy and can drop into the vitreous. And vitreous in the cortex in the vitreous can actually cause raised IOP, which can stay for a prolonged time. It can at the least cause floaters to the patient, and it can be very irritating, and it may cause prolonged inflammation. So it's always good to do a thoracortical wash, be patient, and do it properly. To conclude, it requires skill, and more so a good judgment about the extent and timing of the vitrectomy, when it is needed, and how to remove the cortex. Ideal would be to remove all the cortex, but having said that, it is good to recognize when to leave it a bit if you feel that the PCR is likely to extend. In short, good management leads to good post-operative outcomes in the immediate post-operative period as well as in the long term. Thank you very much.